Hello, everybody. This is Allie Orwig with the Indiana Rural Health Association. We appreciate you joining us today. We are thrilled to have with us Alexa uh, Abel from the National Rural Health Association and our own Dan Hardesty, Director of Government Affairs at IRHA. But before I turn it over to them, I will go ahead and do just a couple quick housekeeping items. This is a flex-funded event, so we will have a poll for you at the end of today's session. Collecting this data is critical for us to be able to continue having these free educational events for you, so we do hope you'll fill that out for us. We are recording today's session, so if you're not able to join us for the full time, or if you would like to reference it, it will be up on our YouTube channel, hopefully by the end of the month, where you can share with colleagues or post wherever you would like. During today's session, we will take questions throughout. We will hold them for a couple different periods throughout the presentation. Alexa will answer those questions, but please feel free to use either the chat or Q&A function. We will keep an eye on those during today's presentation. You access those by hovering your mouse over the screen. Options will pop down either from the top or the bottom, depending on which view mode you're in. You should be able to find those fairly easily. Alternately, if you would like to hold your question until the end of the session, you can also use the raise hand function, which will allow us to unmute your line and you can ask your question verbally. Well, without further ado, those are all of my items. And Dan, I will go ahead and turn it over to you.
Thank you, Allie. Good afternoon, everyone. Welcome to our Lunch and Learn on the One Big Beautiful Bill. As Allie said, we have the pleasure of having Alexa McKinley Abel from the National Rural Health Association here to go in depth as to what's in the bill. And we'll have a brief discussion about Indiana-specific items after that. And then as we go through all of this, as Allie said, please feel free to submit your questions. Alexa is the Government Affairs and Policy Director at the National Rural Health Association. She joined NRHA in 2022 and leads NRHA's executive branch advocacy and legislative advocacy, providing policy expertise and technical assistance to government stakeholders. Her portfolio includes Medicare and Medicare Advantage, rural hospitals, graduate medical education, 340B, and oral health, obviously all incredibly important to rural health. She received a JD from the University of Pittsburgh Law School in 2021 and a Bachelor of Arts in Political Science from Michigan State University in 2018. Alexa, go ahead and turn it over to you.
Thank you, Dan. And thank you for having me today. As was mentioned, I will be going over some of the provisions from the reconciliation package or the One Big Beautiful Bill, whatever you want to call it, that have direct impacts on rural health. And I'll also talk about the Rural Health Transformation Fund that was included in the bill as an attempt to offset the cuts that rural health will see through Medicaid, marketplaces, etc. So this is what I'll be going over today. I'll touch on the major provisions on Medicaid, the Affordable Care Act marketplaces, Medicare, SNAP or the Supplemental Nutrition Assistance Program, and some changes to student loans that will have an impact on the healthcare workforce. And then I'll go through what we know about the Rural Health Transformation Program so far. And I'm sure I'll say this later, but there are a lot of gaps that need to be filled by the Centers for Medicare and Medicaid Services, or CMS, around how this transformation program will be implemented and around the application process. So I'll do my best to explain what we know so far and where we need further guidance from the agency. And before I get into some of that, I really want to stress some of the impacts of this bill largely across the healthcare system. There was a Congressional Budget Office score that was released yesterday on the final package. It's projected to add over $3 trillion to the federal deficit. Even with all of the cuts to the federal healthcare programs, this is still a costly package, and all of the provisions that cost money were not offset fully by the cuts we saw in healthcare and elsewhere. And the most recent projection around uninsurance, this is not specific to rural, but about 10 million people will become uninsured in the next 10 years. This is slightly less than the initial projection because there were some provisions removed around immigration status, or things were changed. So that removed a subset of the population that could become uninsured from this projection. Specific to rural health, though, KFF anticipates that when all is said and done, this package will cause the federal Medicaid spending in rural areas to decrease by $155 billion. Before I get into it, later, I will just note that the transformation program only allots 50 billion across the country, and it's over 5 years, whereas this is kind of cuts over a longer term. And there's a subset of states that will be expected to see the largest losses that are on this slide. Of course, all states will feel these cuts, those just based on the population, especially the Medicaid expansion population in those states. That's what would lead them to see bigger decreases in Medicaid spending. And with that, I'll move on to some Medicaid provisions. So I'm going to talk about this primarily in terms of eligibility and enrollment provisions and then financing provisions, and then there are some miscellaneous ones as well. But the eligibility and enrollment and financing are really the ones that will have the largest impact on rural health. So first, there were provisions to delay two regulations from going into effect for about 9 years, so until October 1st, 2034. These rules that are supposed to streamline and simplify enrollment in Medicaid, CHIP, and Medicare savings programs, which is for dual eligibles, these will not go into effect. So that was identified as a cost saver because people will fall off or not stay in these programs or not enroll as easily as if they were put in place and implemented in the next couple of years as they were supposed to be. There's also some changes around ensuring address and eligibility verification that states will have to implement. So they will have to kind of create a system to obtain in Medicaid enrollee address information from reliable data sources. And then HHS will have to create a system where states can share this information across states to ensure that there's no duplicate enrollment. And then states will also be responsible for reviewing master death files quarterly to make sure that deceased individuals are no longer enrolled in Medicaid. There's also some restrictions around what qualified immigrants are able to enroll and get coverage through Medicaid. So it's quite limited compared to current. So certain Cuban and Haitian immigrants will be eligible for Medicaid, COFA migrants, and children and pregnant adults that are covered under the Legal Immigrant Children's Health Improvement Act. So it's a small pool of immigrants that are considered qualified for Medicaid coverage. Additionally, two bigger provisions that will have an impact on people staying enrolled in Medicaid are retroactive eligibility and eligibility redeterminations. I'll actually start with the eligibility redeterminations. This is only for the Medicaid expansion population of adults. They'll see their eligibility redetermined every 6 months as opposed to the current law, which is every 12 months. That will be twice a year. Just by increasing the frequency of eligibility redeterminations, we know people will lose coverage. It will lead to churn. And on top of that, there's changes to retroactive eligibility, which is when someone applies to Medicaid, certain qualified medical expenses from before they were enrolled may be covered by Medicaid. Right now, 3 months prior to enrollment, someone's expenses could be covered. This is changed under the reconciliation package so that those in the expansion population only have retroactive eligibility for 1 month, and the non-expansion or traditional Medicaid population would have retroactive eligibility for 2 months prior. This means that individuals may face more out-of-pocket costs and see more medical debt because certain expenses that would have been covered before are not. And if you pair this with redetermining eligibility and someone falling off because they're not keeping up with what's needed to remain enrolled when they have their eligibility redetermined every 6 months, you may see them get higher out-of-pocket costs because now their retroactive eligibility from when they fell off is also limited. So one big thing I want everyone to take away from today's presentation is that these provisions don't work alone. When you put them all together, they really will have big impacts on the number of individuals who are enrolled in Medicaid as well as the marketplaces. And even if it just seems like it's about coverage, it's not, because that means there's going to be more uncompensated care or more uninsured individuals showing up to rural hospitals and rural clinics that still need to receive care, but those facilities just won't be reimbursed, of course. Another big part around eligibility and enrollment in the reconciliation package is work requirements. Now, these primarily apply to, again, the expansion population of adults. So beginning in 2027, adults between 19 and 64 will have to work 80 hours per month or have 80 hours of community service or be enrolled at least part-time in an educational program. So I've gotten questions about like college students or graduate students who don't get health insurance through parents or school or whatever it might be. They would be exempt from work requirements because they're enrolled in an educational program. And there, I'll go over a list of exemptions, I think, on the next slide. But one thing to note here that is different from versions we saw earlier in the summer versus what was passed is that parents only have an exemption if their children are 13 and younger. So if there are parents of 14, 15-year-olds, they would then be required to start to comply with the work requirements. Compliance will be determined at application and then every 6 months after that because it's at every redetermination. And like I said, this is really targeting the Medicaid expansion population. So at application, states can look back at compliance with work requirements for up to 3 consecutive months immediately prior to that application. And then at redetermination, they just can look back 1 month. States do have the option to verify compliance more often than just at redetermination. So, a state may choose to say they want to look at compliance with work requirements every month. Do I think that will happen? I don't know, because that would be very administratively difficult on the state's part, but it is possible based on the language in the bill. And then states also cannot apply for any kind of waiver that would exempt the whole state from work requirements. This is just going to happen in every Medicaid expansion state. Exemptions, again, parents 13 and under would be exempt. Pregnant or postpartum individuals that are eligible for Medicaid coverage are exempt. Parents and guardians of individuals with disabilities, members of tribes, individuals with disabilities themselves, individuals with substance use disorder, or those in drug or alcohol treatment programs, certain veterans, and individuals meeting work requirements for other programs like SNAP would also be exempt. There are also short-term hardship exemptions that would be available. So if a natural disaster hits an area, or if someone is in inpatient care for a portion of a month, they would have a kind of waiver for that month, or whatever applicable months for the work requirements. And then a couple of notes, if individuals are non-compliant, there's a process that states must follow and give them an opportunity to prove that they are compliant. If they're not, they will of course be unenrolled or disenrolled. And another source of affordable healthcare coverage, of course, is the marketplace. However, if someone is found non-compliant with work requirements, they will actually be ineligible for subsidized marketplace coverage. They would basically be banned from the marketplace. And then one change, again, that we saw in the final bill is that there was some money allotted to HHS and the states in order to implement the processes associated with making these work requirements work. In terms of financing, there are a few big provisions here. One is that states that have an expanded Medicaid will not get a bump to their traditional FMAP. And Section 1115 demonstration waivers must be budget neutral. But the really big ones are around provider taxes and state-directed payments. So in terms of provider taxes, these are taxes by the state on certain classes of healthcare providers. When they get when the state receives the money from those providers, it essentially pulls down federal Medicaid funding as well. And then that all goes back kind of into the Medicaid program and can be redistributed back out to healthcare providers at a higher rate than they were taxed. It accounts for about 70% of all state Medicaid financing, at least as of a few years ago. And it's a big way for expansion and non-expansion states alike to help finance their non-federal share. So this bill for expansion states would phase down provider taxes to a threshold of 3.5%. So right now, every state is different, but they can have provider taxes up to 6%. This would phase that down so that the limit is up to 3.5%. So starting in fiscal year 2028, Each year, these provider tax rates will be phased down by 0.5% until 3.5% is reached. On top of that, there are no new provider taxes that may be added after enactment, and that would apply to non-expansion states as well, whereas the phasing down only applies to expansion states. And then this applies to all provider taxes except those on nursing facilities and intermediate care facilities. So we kind of see this change from the initial proposal as recognizing that nursing homes in particular are extremely reliant upon Medicaid funding. Of course, rural hospitals, et cetera, are as well, but they only carved out nursing facilities. And then in terms of state-directed payments, essentially state-directed payments are the states telling Medicaid managed care organizations how much they should pay certain provider types. So these payments will be capped depending on whether a state is an expansion state or a non-expansion state. So expansion states are limited to 100% of the Medicare rate for their state-directed payment rates. Non-expansion states have a little bit of an incentive there to stay non-expansion, and they're capped at 110% of the Medicare rate. If there are state-directed payments that go above these applicable Medicare thresholds, they will begin to be phased down, like the provider tax provision. So starting in 2028, they'll be phased down by 10% until the allowable Medicare rate is reached. There are a couple of grandfathering provisions, but I want to be really clear here that this is not like grandfathering them in forever. So if a state, for example, submitted to CMS a state-directed payment plan that would direct MCOs to pay rural hospitals a particular amount, anything submitted to the CMS prior to the bill enactment that would affect rural hospitals can remain above that Medicare rate until 2028. For any other state-directed payment plans that were submitted to CMS for approval, let's say it was for like nursing facilities, those had to be submitted prior to May 21st, 2025, or May 1st, 2025, and they can remain above the applicable Medicare rate until 2028 comes, and then they all become phased down. Whereas if today a state submitted a new state-directed payment plan to CMS for approval and it was above the Medicare rate, it would just be rejected. So the grandfathering is really only for that small period of time from when the reconciliation process kind of began until either May 1st or for rural hospitals until this bill was enacted on July 4th. I don't know if I did a great job explaining that, and I don't know actually if that impacts Indiana, so I'll leave it at that and can answer questions that may be state specific after.
Sure. So we do have some questions that have come in, Alexa, and possible that you've answered a couple of them. But what is the time frame for the 155 billion spending reduction? When will it occur? Immediately? Over 5 years? Over 10 years?
So that was a projection from KFF, and I want to say it was over 10 years, but I can follow up after this webinar and I can send Dan the link to that report from KFF to share with you all. I think it was over that 10-year period though.
Okay. Are those with mental health disorders part of the disabilities grouping?
So if they fall under the definition of medically frail, which I'm not super familiar with, I'll be very transparent, they may, or anyone who would fall under that like traditional Medicaid population would be exempt from the work requirements. There's also provisions in there for someone with substance use disorder, like I said. Unclear how that would be proven. There would have to be some documentation shown to the states. So someone with substance use disorder could be exempt, or if you're in an alcohol or drug treatment program, again, providing that documentation, that individual would be exempt from work requirements while they're in that program.
Okay. Talking about the application denials, does this mean that someone's application could be denied because they don't meet work requirements prior to the application?
Yeah, they'll look at the month before. So it's not like once you're enrolled, then you meet it. They will be able to look back to that month prior to application to see if you are working 80 hours per month.
Okay. How is the immigrant population affected?
Let me go back. So Medicaid eligibility would be restricted in that last bullet to those immigrant populations. So it's a small group of qualified immigrants that are able to get Medicaid coverage.
Okay, that's all the questions. I will say we've had several people ask about the slides. We will go ahead and drop those into the chat so everybody can access those. We will also send out the recording link and the slides to all registrants once we have those posted.
Great. So I think this is the last slide around Medicaid financing, but for a portion of the expansion population, states will impose cost sharing. It will be up to $35 and it exempts certain services. So for primary care, mental health, substance use disorder services, there would be no cost sharing, as well as services provided at FQHCs, rural health clinics, and any behavioral health clinics. And that would go into effect in FY 2028. And then the last part, this is kind of some miscellaneous provisions around Medicaid that have to do with long-term care. One is that there is a moratorium or a delay of implementation for the minimum staffing standards for long-term care facilities until October 2034. So that's similar to those eligibility and enrollment rules that were also delayed. I will say a court has struck down this rule and said CMS did not have the authority to promulgate it. So I think regardless of the court decisions, basically all things considered, this rule is not going to go into effect. In terms of eligibility for Medicaid coverage for long-term care, they look at certain assets that individuals have, and so this reduces the maximum home equity limits to 1 million. So someone's home equity can only be worth 1 million. That's regardless of inflation. However, there is some language in the bill that would create exceptions for homes on farms or agricultural land that's going to be worth a bit more. And then last, there was a provision added in to the Senate bill and then what ultimately passed that would allow states to establish certain home and community-based services waivers for people who do not need an institutional level of care but could use these types of services. So that's it on Medicaid. I know I took some questions. I'll pause quickly to see if anything else came up. Okay.
We do have a question. Actually, Dan, it probably is a question for you. Does IRHA plan to work with the state to apply for rural transformation funding?
Yes, we are providing information to FSSA on that, the Rural Health Transformation Fund. It'll ultimately be up to them as to what they submit, obviously, but we are actively working with them and providing them as much information as we can.
Great.
Thanks, Dan.
So I'll now move on to the Affordable Care Act marketplaces. If you had been watching other iterations of this bill before it was passed, there were a lot more changes to the marketplaces than what was eventually passed. So there's only a few things that I'll go over here. So beginning in 2026, premium tax credits will be prohibited for individuals who enrolled in a marketplace plan through an income-based special enrollment period. So essentially, during the Biden administration, there was a new special enrollment period created for individuals that had incomes under a certain percent of the federal poverty level, and they could enroll in a marketplace plan during the special enrollment period each month. Normally, you can only do it during a qualifying life event or during the open enrollment period. So this just provided more opportunities for people to change or enroll in marketplace coverage. This is essentially getting rid of that for anyone who used premium tax credits. Again, this wouldn't affect the tax credit availability for those who qualify under other special enrollment periods, like a change in a family size, which is a qualifying life event. And then with the enhanced premium tax credits, this is you essentially get this premium tax credit, enhanced premium tax credit applied to your coverage. It goes right to the health insurance plan, and lowers your costs. And then it's based on estimated income. So when you file your taxes and have your true income, if there's any discrepancy or you said your income was lower than it actually turned out to be, you would have to pay back some of that enhanced premium tax credit. Right now, there are limits on how much individuals have to pay back when that happens, but beginning in the 2026 tax year, all enrollees who underestimated their income for the purposes of enhanced premium tax credits would have to repay that amount in full. There would be no more limits on, or there would no longer be a limit on how much they have to repay to reduce costs for them. And then beginning in 2028, there's a provision that will essentially end automatic re-enrollment in marketplace plans. This is for people who have subsidized marketplace plans, which is really anyone who gets a premium tax credit to help offset their monthly costs. This is the population that essentially needs help paying for health insurance coverage. So because they have a certain income level, they get subsidized marketplace coverage. But beginning in 2028, there will be some new steps around verification of eligibility for subsidized marketplace coverage that will essentially require an individual to affirmatively say that they are still eligible, and they'll have to do that each year rather than just being passively re-enrolled like anyone with employer-sponsored insurance. Like, for example, I don't have to give any sort of I don't have to check any sort of box each year. I just stay in my plan. That will be ended for people with subsidized marketplace coverage. So you can imagine people will fall off or lose their coverage because they don't take those affirmative steps to say or to show that they're still eligible. They may still be enrolled in a plan, but they won't be receiving the tax credits that make that plan affordable. So essentially, they will be paying a lot more out of pocket or just losing coverage in general. And then beginning in 2028, individuals will be barred from receiving tax credits if they don't file a tax return for the prior year or they don't reconcile with a previous enhanced premium tax credit. So that's what I was talking about earlier. When you have your estimated income versus your actual income and reconciling that, if they don't do that, they will be barred from receiving that in the future, the tax credits in the future. And then again, a similar limitation on what immigrant populations are eligible for subsidized marketplace coverage. So I will pause again to see if there's any questions around the marketplaces.
One person did ask, what is happening to package E? Is that going away as well?
I don't know what package E is. I don't know if someone could explain it, maybe I could try, but otherwise I might have to pass on that one. Okay. And then I will move on.
Emergency Medicaid is what the clarification that they provide. Emergency services only, limited coverage for immigrants.
Oh, I'm not as up to date or up to date on some of the immigration provisions in there, just because we don't have a lot of association policy around what we say on immigration. But I can double check on that and again get back to Dan to see if he can follow up with that for everyone. But I'm not gonna actually guess there. So now just a couple of provisions around Medicare. There wasn't much regarding Medicare in this package, but I do just want to bring some attention to it. There was a temporary increase to the Medicare physician fee schedule. If you know anything about the Medicare physician fee schedule, there's been big cuts to physician payment the last couple of years. So this is a temporary increase for 2026 of 2.5%. And then again, restricting Medicare eligibility to certain immigrant populations. Since there wasn't much there, oh, I don't know if there's a question in the Q&A. Nope. Okay. So now we'll move on to SNAP. I really do want to highlight this because at least for state budget purposes, it will have a cumulative impact when paired with some of the financing changes to Medicaid. So part of that is historically the federal government has paid the cost of food assistance, so the actual benefits that SNAP recipients receive, where states pay a share of the administrative costs of SNAP. Now there's going to be a change to that will essentially shift some of the cost of paying for the direct like food assistance, food benefits to the states based on their payment error rates. So states that have payment error rates above 6% will have to pay a portion of the food assistance. There's like a sliding scale, but it could range from 5 to 15% of food assistance costs, which again has never been done before. So that's another strain on state budgets. And then there's just a calculation that they're going to use in order to determine the amount that states will pay after FY 2029 for food assistance. Another change to what states will have to pay for SNAP is around administrative costs. So right now they split administrative costs. 50% is paid for by the federal government, states pay the other 50%. Beginning in fiscal year 2027, states will take on 75% of the administrative costs. So they're getting another 25% that they'll have to pay. Again, put that on top of restrictions to provider taxes that will go into effect in a couple of years, people falling off Medicaid. These two things together are going to strain state budgets that I think are already quite strained. And then there are just a couple of changes to SNAP work requirements. SNAP work requirements have been in place, but this is expanding the population that has to comply to 54 to 64-year-olds. So right now, just 18 to 54-year-olds have to comply. They're increasing that age limit to 64. Waivers would only be available in places where unemployment rates are over 10%. And then the last SNAP provision is that SNAP Ed would be ended. Essentially, this is a program through SNAP at USDA that just provides education on healthy eating and obesity prevention. So that will no longer exist. And again, I'll stop there to see if there's any questions. Otherwise, I can move on to the student loan sections. So I do want to talk about some changes to graduate loans because they will impact med students and other graduate healthcare professional students and may serve to turn some students away from going into the medical field because the costs would just not be something that they could reasonably take on. So this is really going to impact people who come from families that don't have the means to pay for their medical school or other schooling. And drive some people away again from the field when we're already facing workforce shortages and have projections of physician shortages with really crazy numbers into the future. And as older physicians and older practitioners begin to retire. So the Grad Plus program is a program that allows students to borrow up to the full cost of attendance, so pay for any tuition that may not be covered through like merit scholarships, pay for living expenses, a really important program for graduate students, and many med students rely on it as well. This program will end next July, so someone who's borrowing from the Grad Plus program right now, they're fine, but no new borrowers for the next year will be able to benefit from this program. On top of that, unsubsidized federal graduate loans will have caps for students. So grad students would have a cap of $20,500 per year with a $100,000 lifetime cap. And then for professional students, which includes medical students, they would only be able to borrow up to $50K per year with a $200,000 lifetime cap. That may sound like a lot, but if someone has to pay fully out of pocket for medical school costs more than $200,000 if no one's getting scholarships or help elsewhere. So that means that individuals may have to move to private loans. And again, if someone's not willing to take on debt from private loans, they may not attend medical school. So we are just concerned about the downstream workforce effects that these changes may have. And then I'm not going to get into the details on this, but right now for individuals that have federal loans, there's income-based repayment plans that essentially make it more affordable for you, and it's based on how much you make, which makes sense. This bill would get rid of all of those income-based repayment plans and replace it with one that will, for I think almost everyone, increase their monthly student loan payments. So I'll pause there. I'm going to transition to talking about the Rural Health Transformation Program, but just want to see if there's any questions about anything I covered so far.
I don't see
No
any, Alexa.
questions.
Okay.
No.
All right. Now what everyone's been waiting for, I think. The Rural Health Transformation Program. Like I said, this was included in the final reconciliation package as a way to help offset some of the cuts that we will see due to Medicaid and other changes in the bill. There were, if you were paying attention to this whole process, obviously a couple of vocal senators who were worried about the impacts of Medicaid cuts on rural hospitals in particular. This appeared to be something that was added in to kind of assuage those concerns and get them to vote yes on the bill, and also put some money into rural communities. This is, from NRHA's perspective, a great idea. A transformation program is, exactly what rural health needs. However, that being said, this does not make up for the cuts that are in the bill. I shared earlier the projection of $155 billion decrease in federal Medicaid funding going to rural communities over the next, I think it was 10 years. This is $50 billion over 5 years. So we 100% understand that this is not a trade-off. This is not a one-for-one. It's not going to make up for the Medicaid cuts. And on top of that, this isn't the same as a provider getting Medicaid reimbursement. This is going to be distributed to the states and then likely by the states distributed out across the state to providers or however they plan to do it. So it is not a one-for-one for the Medicaid cuts. I just want to put that kind of caveat out there. So again, this is a $50 billion fund that will be distributed over 5 years, beginning in FY 2026 through FY 2030. It will be $10 billion each year across all states. Eligibility for the funds looks like 50% going to all states equally, and the other 50% being distributed to states based on CMS's discretion. CMS does have some guidelines it has to follow that was in the legislation as to how they will distribute that second 50%, but there is still some discretion for CMS there. I also want to note, you could do the math on how much each state will get from the 50% equal distribution, but because states have to apply, there is the potential for a state's application to be denied. So it may not be to all 50 states technically, although I can't imagine that will happen. So how do states get the funds? They don't automatically get anything. Even though there's 50% that's supposed to be distributed equally, they still have to apply. So that looks like an application to CMS, which we are still waiting for any guidance or information on. CMS has not put anything out. We don't know exactly what it will look like, but there is some information in the statute now that says they have to have a detailed rural health transformation plan. And there's a couple of lines in the bill that explain like what that should include. States will also have to certify that they're not using any of this for intergovernmental transfers, public expenditures, or any other expenditure that essentially finances the non-federal Medicaid share. So it's quite literally not making up for some of the Medicaid cuts. This is also a one-time application. So states just have to apply this year, and CMS must approve or deny all applications by the end of 2025. So the timeline is quite short, especially because we haven't seen anything around applications yet, but we know that CMS has to approve them by the end of this year. And it's a one-time application. So essentially the 50 billion will kind of be decided upon by the end of 2025, but the distribution will happen over 5 years. Again, more detail on the form, manner, and even the deadline for applications will be released by CMS hopefully soon. We're almost in August. That gives a few months really until the end of the year. And we would imagine that CMS will give at least a couple of months for states to apply. So we think we should see something relatively soon. But again, we don't know much around the application process yet. And then looking at that, what I'm calling the second 50% of funds, or the discretionary funds that CMS can distribute, these are the guidelines that CMS has to follow to decide how to allocate that remaining 25 billion to the states. So one thing they have to look at is the percent of the state population that's located in a rural census tract or a rural area. They have to look at the proportion of rural health facilities in the state relative to the number of rural health facilities nationwide. The situation of rural hospitals in the state, so think financial situation. And then this is where I mean that there is some serious discretion left up to CMS. There is a provision that says any other factors deemed appropriate by the CMS administrator. Now, I do want to clarify again that this money isn't just going to be given right to rural hospitals or rural clinics in the state. It will go to the state. So when we're thinking about the list of what qualifies as a rural health facility in this legislation, that doesn't mean that is who is just going to get payments. You'll see on this slide, again, the proportion of rural health facilities in the state relative to the number of rural health facilities nationwide. This list is what counts as a rural health facility for purposes of calculating that, to then determine the allocation of that 25 billion that CMS has more discretion over. So with that clarification in mind, this is the list of facilities that are considered a rural health facility for that count. So we have all of the usual suspects: critical access hospitals, sole community hospitals, low volume hospitals, rural emergency hospitals. But note that hospitals that are being treated as rural or reclassified hospitals count. I know for a fact there is a large hospital in Boston, Massachusetts that is reclassified and considered rural. I think that's the case in a lot of states and a lot of metro areas. Their hospitals have reclassified to rural for payment purposes through what is a completely legal loophole. So they will count towards that number of rural health facilities, as will all FQHCs, even if they're not in a rural area, and all community mental health centers. So there are a few terms and conditions around the funds, which the CMS administrator, again, has some discretion to write on his own. But some of them are that states have to submit annual reports on how the funds are being used. States have to submit a plan for how it plans to use its funds based on certain specified activities that they're allowed to be spent on, and then not more than 10% of the funds can be used for administrative expenses. So this is where we can kind of answer the question, what can the rural health transformation funds be used for in the state? There is a pretty long list, so it's these two slides, and Pretty broad language. CMS may come out in the application and have a little bit more detail around what this means, but these are the guardrails or the guidelines that the legislation that Congress has set. And then it will be up to CMS to kind of interpret that and decide what falls within these classes of activities. So when states submit that plan for how it's going to use the funds, they have to show how they're going to carry out at least 3 of the following. That includes promoting evidence-based interventions to improve prevention and chronic disease management, payments to providers, that's a big one, promoting technology-driven solutions for management of chronic diseases, training and technical assistance for adopting technology-enabled solutions that improve care delivery in rural hospitals. So you can see where that language is quite broad. Recruiting and retaining clinical staff with a commitment to stay for 5 years in a rural community. Technical assistance software, hardware for technological upgrades and for things like cybersecurity. Supporting OUD, SUD treatment, assisting rural communities to right-size healthcare delivery. Again, pretty broad language. Projects that support value-based care. And then again, CMS is given pretty broad discretion, and the legislation says additional uses designed to promote sustainable access to high-quality rural healthcare as determined by the CMS administrator. One note I want to make here, so on the last slide, payments to providers is an acceptable use of funds, and it's payments for services and items, so, payments to providers. But healthcare provider is defined as any provider participating in Medicare and Medicaid, and again, I want to differentiate that from the rural health facility definition that I went over. So this is not specific to rural providers. Some more conditions around how funds can be used. They have to be used within a certain time frame. So funds have to be used by the end of the fiscal year following the fiscal year in which they were distributed. So what's distributed in FY 2026 must be used by the end of FY 2027. And then any funds that are left over beginning in 2028, CMS will start to determine how much that is and how to redistribute them to other states. There's a provision that says if CMS determines a state is misusing the funds, they can withhold them, reduce them, or recover payments from the state. And then again, funds can't be used to finance the non-federal Medicaid share. So that's the information we have on the Rural Health Transformation Program. Before I take some questions, I just want to note that we are trying to work on some resources to help state rural health associations and state offices of rural health engage in this process. Right now we are, and it sounds like Indiana Rural Health Association is already on this, but we are encouraging SRHAs and state offices of rural health to if they don't regularly already, to engage with their governor's office, their state department of health, and ensure that those stakeholders know who you are, so that rural has hopefully an opportunity to participate in creating that rural health transformation plan and submitting that application. I know we've heard lots of concerns from stakeholders that these funds will not reach rural areas, and there's definitely language in the legislation that does concern us that that's a possibility. So we are working with our state partners again to make sure that they are able to participate in the application process in their state. So I will stop there and take any questions. And if you have any questions that come up after this, please feel free to shoot me an email. I'm happy to help.
So one person asked, will the Indiana State Legislature have to approve the request for federal funds?
Like the application, I don't think so. The application for the Rural Health Transformation Program will just go to CMS, and then CMS will approve or deny. And from our understanding, it would be like the governor's office or the State Department of Health that will be doing that application. But again, we're waiting for that guidance from CMS to know for sure.
Okay. And then are Pell Grants going to still be available?
I believe so. I don't think that the final bill included anything around Pell Grants, but I know that had been part of the discussion earlier this summer.
Okay. As I mentioned at the top of our call, I am going to go ahead and launch our quick poll here that helps us have these sessions. So please take a second. It is just one question. But if you could potentially go ahead and answer that for us, this is how we continue to have these flex funded presentations. At this time, we will go ahead and leave it open for questions and answers. Dan, if you have anything you want to add today, please do so now. And also, if anybody wants to use the raise hand function to ask a question aloud, we will allow for that at this time.
Very good. I have just a couple of slides to go over, and I'll be very brief in this. I wanted to give a quick kind of background for our members and people on the call today, highlighting the provider tax provision specifically. So looking specifically to Indiana, Indiana utilizes what's called the hospital assessment fee, or HAF. And in 2024, Indiana hospitals paid an estimated $1.6 billion in assessment fees to leverage over $5 billion in Medicaid funds. Within the HAF, the state retains 28.5% of the HAF revenues as administrative fees. And the current, and I've underscored current because on the next slide, you'll understand that we are currently, I say we, the state is currently working to redesign how our provider tax operates. But the current calculation is inpatient days, which is capped at 6%. And as Alexa mentioned earlier, anything that's the 6% will be throttled back in coming years. And then also outpatient revenue comes into play. I believe that is capped at 4.5% in Indiana right now. And then to kind of put this all in perspective, early on in the reconciliation discussions, a lot of think tanks and different associations are working to understand the potential impacts. But the American Hospital Association estimated 64,000 rural Hoosiers would be off of our current Medicaid, and rural hospitals would take a $1 billion hit. So again, as I mentioned earlier, House Enrolled Act 1004 from this past session allows FSSA to redesign the HAF to a state-directed payment program. Within that legislation, there will be hospital classes for the state-directed payment program. So again, this dovetails very nicely with what Alexa covered just right before this. And rural hospitals and critical access hospitals will have their own class, and that will allow the state to move around the new dollars through the state-directed payment program to different classes. Also moving the calculation to 6% of net patient revenue instead of the inpatient and outpatient delineation. And as I've already mentioned, FSSA has submitted a preprint or an application to CMS with also a managed care assessment fee was also submitted. So this is my last slide. I know it's really busy, but I'll make sure to drop these in the chat as well so you can take a look at this. We have a lot going on in the Hoosier State right now when it comes to healthcare. A lot of stuff happening. And this is obviously, I have a little disclaimer on there, non-inclusive to everything that's going on, either at the state level and obviously at the federal level as well. But this is kind of a timeline of everything that's going to play out in the next couple of years. There is enhanced nonprofit hospital financial reporting that is will be mandated this year. It's beginning of next year, looking at greater transparency through a number of healthcare industries in the all payers claim database. And then 2026 is the hopeful date that we will transition to the state directed payment program. And then we also have a lot of these new deadlines coming in through the One Big Beautiful Bill, with the Rural Health Transformation Fund right now authorized for 5 years. The Medicaid work requirements and eligibility checks start in 27, and then the provider tax phase down in 28. So a lot happening right now. There's my email and also Alexa's information as well. But I will stop there. I know we are coming very close on 1 o'clock, and I'd be happy, and Alexa would be happy to take any questions.
Two questions have come in. Will Medicaid for patients with asylum be affected?
So I think that the definition of like qualified immigrant that I went over, that's who would be eligible for Medicaid, and that did not include asylum seekers. But again, the immigration stuff, not my forte. Let me just double check that that is the case, that they would not be able to access Medicaid any longer, and then again, send it over to Dan, and hopefully he can get some follow-up out on that.
Okay, we had someone ask in the chat, is WIC being reduced along with SNAP? And no, there were no changes to WIC in the reconciliation package. Another question, how do you expect the federal and recent state bills to impact overall inpatient Medicaid days and dish percent in Indiana?
I mean, I
That's
can,
a really,
oh, go ahead.
with the new state directed payment program, Dish is also changing as well. So that's something that I'd be happy to look into a little bit more because it is very state specific. If you want to, you can send me an email. I think that was an anonymous person. You can send an email directly to me, and I'd be happy to dive into that.
Okay. I think we answered this one earlier, maybe not. Are those with mental health disorders part of the disabilities grouping for Medicaid?
So there's specific provisions. So as it pertains to work requirements, there are specific exemptions for individuals with substance use disorder and those participating in drug and alcohol treatment programs. And then I'm not super familiar with what is included in this definition, but those that are considered medically frail, which I think may include certain mental health disorders, would also be exempt from work requirements. But I think, overall, if you don't fall into those kind of specific categories, they wouldn't be exempt.
Any other questions? Well, Alexa, Dan, we are right up against the 1 o'clock hour. Thank you so much for this absolute dearth of information today. A lot of questions and now hopefully some guidance on a lot of those questions. But we will go ahead and get this up. Hopefully by the end of the month, we will get the recording and slides out to everybody. The slides were dropped in the chat. If you want to grab those before you jump off today, you'll have those immediately. And certainly, if anything else comes up, please do reach out to Dan or Alexa for more. It looks like we do have one person with their hand up in the attendees that would like to ask a question. Nope, the hand went down. Okay. Just kidding. All right. Thank you, everyone. Have a great day.
Thank you.